Welcome to The Explainer. Today, we are diving deep into a really high-yield topic for your exams and for your future clinical practice, systemic lupus erythematosus, or as you'll see it, SLE. Let's get right into it.
So let's start with a big question. What if the very system that's designed to protect you, your immune system, got its wires crossed? What if it started launching attacks against your own healthy tissues, your skin, your joints, your kidneys, even your brain? Well, that's exactly what happens in systemic lupus erythematosus.
So what is SLE, really? At its heart, it's a chronic autoimmune disease. This means the body's B cells start making something called autoantibodies, which are antibodies that mistakenly go after the nucleus of your own cells. This mistake sets off a chain reaction of inflammation and damage just about everywhere, which is why we call it systemic.
Now, who gets SLE? It's really striking. It overwhelmingly affects women, particularly during their childbearing years. We're talking a 9-to-1 female-to-male ratio. That's a classic demographic, a huge clue you'll want to remember for any exam question.
Okay, so you have to wonder, how does a perfectly healthy immune system go so haywire? Well, the best way to think about how SLE develops is as a two-hit process. You don't just get it out of the blue. It takes the right combination of genes plus some kind of environmental trigger. Let's unpack how that works.
So hit number 1 is genetic susceptibility. Having certain genes, like HLA-DR2 and HLA-DR3, means you're already at a higher risk. But genes alone aren't enough. Then comes hit number 2, an environmental trigger. This could be anything from UV light from a day at the beach to cigarette smoke or even certain medications. This trigger damages the body's cells, causing them to die through a process called apoptosis. Now, your body is usually great at cleaning up these dying cells. But in someone with that genetic predisposition for SLE, the cleanup crew is a bit slow. This means nuclear material gets left out in the open, and the immune system sees it. The B cells get confused, think this stuff is a foreign invader, and bam, they start pumping out those harmful autoantibodies.
And these autoantibodies aren't just floating around doing nothing. Oh no, they grab onto those nuclear antigens and form these little clumps called immune complexes. Think of these complexes as the real troublemakers. They travel through the bloodstream, get stuck in tiny blood vessels all over the body, and kick off a massive inflammatory response. This is a classic type 3 hypersensitivity reaction, and it's the direct mechanism that causes all that widespread organ damage we see in lupus.
So we've covered the microscopic battle happening inside the body. But how does that translate to what we actually see when a patient walks into the clinic? Let's connect the pathophysiology to the signs and symptoms.
Let's start with the skin. The most iconic sign of lupus is the malar rash. You'll hear it called the butterfly rash because of the way it spreads across the cheeks and the bridge of the nose. Here's a key clinical pearl. It almost always spares the nasolabial folds. Those are the smile lines running from your nose to your mouth. And patients will often tell you they're photosensitive, meaning that just being out in the sun can trigger their rash or make all their symptoms worse.
Next up, joints. Joint pain is incredibly common in lupus. We're talking over 90% of patients. They usually get asymmetrical arthritis, so it'll affect both wrists or both knees, for example. Now, here's an important distinction. Unlike rheumatoid arthritis, lupus arthritis is typically non-erosive. That means it causes pain and swelling, but it doesn't actually destroy the bone.
The kidneys are a huge deal in lupus. This is one of the most serious things we watch for. When those immune complexes we talked about get lodged in the kidney's filtering units, it causes a condition called lupus nephritis. This is a very severe complication that can lead to kidney failure, which is why we're always checking the urine for any signs of protein or blood.
And remember, lupus is systemic, right? So the attack can happen anywhere. It can go after blood cells, causing anemia or low platelet counts. It can affect the nervous system, leading to anything from seizures to what patients call brain fog. And it can inflame the delicate linings of the heart and lungs, a condition we call serositis, which causes really sharp chest pain.
So, with all these possible symptoms, how do we actually diagnose it? We use a panel of very specific blood tests. Think of the anti-nuclear antibody, or ANA, as your go-to screening test. It's super sensitive. Almost everyone with lupus will have a positive ANA. But lots of other things can cause a positive ANA, so it's not very specific. To really lock in the diagnosis, we look for 2 others, Anti-dsDNA, which is great for tracking disease activity, especially kidney involvement, and the anti-Smith antibody. Anti-Smith is the most specific test we have. If that one's positive, you can be pretty darn sure it's lupus.
You know, diagnosing lupus isn't about one single test result. It's really like putting together a puzzle. The official diagnosis is usually made when a patient meets at least 4 out of 11 specific criteria. And these criteria are a mix of everything we've talked about. The clinical signs, like the butterfly rash and the arthritis, plus those specific lab results from the antibody tests.
All right, so once we have a diagnosis, how do we manage this? The whole goal of treatment is to calm down that overactive immune system, prevent those flare-ups, and most importantly, protect the organs from any more damage.
Treatment is really a step-by-step approach based on how severe the disease is. For mild cases, where it's mostly skin and joint problems, we'll start with anti-inflammatories and a really important drug called hydroxychloroquine. If the disease is more moderate, we have to step it up to systemic corticosteroids like prednisone to really stamp out that inflammation. And for severe, life-threatening lupus that's attacking major organs like the kidneys or the brain, we bring out the big guns, powerful immunosuppressants, and the newer biologic drugs.
Okay, let's wrap this up. We're going to boil everything we've discussed down to the absolute must-know, high-yield facts that you need to have locked in for your exams.
First, the classic patient. Always think of a young woman with that triad of a butterfly rash, joint pain, and photosensitivity. Second, labs. ANA is your best screening test. Anti-Smith is your most specific test for diagnosis. Third, Anti-dsDNA is the one you follow to track disease activity, especially with lupus nephritis. And finally, don't forget to check complement levels. If C3 and C4 are low, it means the immune system is in overdrive and using them up, which tells you the disease is active right now.
So really, this entire complex disease can be understood with one core idea. If you truly understand this sentence, that a person with the wrong genes gets hit by the wrong trigger, leading to autoantibodies and inflammation, then you've absolutely grasped the fundamental concept of systemic lupus erythematosus.